Alright, we're going to talk here about mesenteric ischemia, and the word mesentery just pretty much means your gut. So we're talking about gut ischemia, mostly the small intestine and large intestine, especially the large intestine. So we'll talk about some basic anatomy of the mesenteric vasculature, which it's good to know it in detail, but we'll talk about, I'll give you some very, very basic things that you need to know. And then we'll just sort of go over some of the basics of the mesenteric vascular diseases, and then we'll cover them in depth. And the reason I want to give you an overview before we talk about them in more depth is because it's good to have an idea of what these all are so you can sort of compare them to one another. All right, so this is your mesenteric circulation and highlighted. And your mesenteric circulation, we're talking about three major arteries, trunks that come off of your abdominal aorta, and those are the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. Now, for the most part, your celiac trunk, it gives off various vessels. Initially, it's going to give off the right inferior phrenic artery, which is going to go up to your diaphragm. It's going to give off the left gastric artery, which comes around here and supplies the lesser curvature of the stomach. And then it's also going to give off your splenic artery, which goes to your spleen. After that, then it becomes the common hepatic artery, coming up here to your liver. But it's not done yet. It gives off two more arteries. It gives off two more branches, that being the right gastric artery, which supplies your greater curvature around here, and then also gives off the right gastroduodenal artery, which supplies the distal stomach and the duodenum. And then after that, then it finally goes to the liver as the proper hepatic artery. So when we're talking celiac trunk, we're talking about the stomach, duodenum, as well as the spleen and the liver. Now your superior mesenteric artery gives off, is going to give off an inferior pancreaduodenal artery. It's also going to give off intestinal arteries, which when we're talking about intestinal, we're talking about distal duodenum, ileum, jejunum. So those supply the small intestine, and then it also gives off an ileocolic artery, which supplies the very distal part of the small intestine, and then the cecum and the appendix, which is the very beginning of the large intestine. And then it also gives off a right colic artery. So on the right side, what do you have on the right side? You have your ascending colon. And then a middle colic artery. What do you have in the middle? You have your transverse colon. So if you don't remember anything else, just remember that your superior mesenteric artery supplies most of your small intestines, and then your ascending and transverse colon. Now, the inferior mesenteric artery supplies your descending colon and then your sigmoid and the superior part of your rectum. So it's going to give off a left colic artery, and the left colic artery supplies, well, what's on the left side? The descending colon. So it supplies the descending colon, left colic artery. And then it also gives off sigmoidal branches, which you can't really see here too much, but that supplies the sigmoid colon, as its name would imply, and then it terminates as the superior rectal artery, which supplies the superior part of your rectum. So if you don't remember anything else, just remember that the inferior mesenteric artery supplies your descending colon and the sigmoid and the superior part of your rectum. All right, so this is just kind of talking, this just shows you verbally what I just talked about. All right, so an overview of the mesenteric vascular diseases. We've got three of them, those being acute mesenteric ischemia. Acute mesenteric ischemia, as its name would imply, would be a sudden and severe loss of flow to the mesentery. Usually what we're talking about here is the colon. And this is a vascular emergency because it's acute, because you haven't developed your collateral circulation, and so this causes problems, and it's actually got an 80% mortality rate. So this is a big emergency, and you need to be able to pick this up right away. So acute mesenteric ischemia. Then we also have chronic mesenteric ischemia, and this is a chronic deficiency of blood flow to the mesentery, and it's not as deadly as acute mesenteric ischemia because you have time to develop your collaterals. This is something that develops over a long period of time. And this is associated with atherosclerosis, whereas acute mesenteric ischemia is usually an embolism or a ruptured plaque. Chronic mesenteric ischemia is almost always associated with atherosclerosis because you're slowly developing a blockage. So if you think back to your lower extremity diseases, your peripheral vascular diseases, you can kind of associate acute mesenteric ischemia with acute limb ischemia and chronic mesenteric ischemia with lower extremity occlusive disease. And you'll see that the surgical treatment that we do for these they sort of mirror what we do for those diseases. And then there's mesenteric venous thrombosis, and what this is it's a thromboembolism from the veins that then go up into the mesenteric veins, or down into the mesenteric veins, up into the mesenteric veins, I suppose it would be, and blocks the veins. And this is sort of like a pulmonary embolism of your intestines. And this is highly associated with hypercoagulable states, just like DVT is. So you can think of this basically as like a pulmonary embolism of your intestines. So these are the three we're going to talk about. Most important is acute mesenteric ischemia because it's got an 80% mortality rate, so we want to be able to point this out quickly and diagnose this quickly. The quicker we diagnose this, the better chances the patient has of survival. So, acute mesenteric ischemia. This is sudden and complete loss of blood flow to the mesentery. It's always associated with a sudden and severe pain if the patient is conscious enough to tell you that they had pain. Sometimes they're not, and usually those patients die. But it's always associated with a sudden severe pain. Why? Because it's acute. It's an embolism or a ruptured plaque. You got a sudden loss of blood flow to the mesentery, and that's going to result in sudden pain. It's just like a heart attack. A heart attack, an MI, you get a sudden loss of blood flow to your heart, and that's going to cause unstable angina. So this is like unstable angina of your colon, of your small intestine. Most commonly, the acute mesenteric ischemia, where you're going to get the disease, is the superior mesenteric artery or its distal branches. Usually it's going to be just a few centimeters distal to where the superior mesenteric artery comes off. So it's going to affect your right and middle colic arteries, and that supplies your colon, and that's why this is associated mostly with the colon. So most commonly it affects the superior mesenteric artery, a little bit more distal than those first couple branches. What are the causes? Sort of alluded to this earlier. Embolism. I would say this would be the number one cause. Embolism, just like with the lower extremity diseases, when you get an embolism, it's often cardiac in origin. So particularly what we're looking for here are AFib patients or post-MI patients. They develop an embolism in their heart, but in this case, it goes to usually the superior mesenteric artery, whereas in the lower extremity, if you had lower extremity disease, sudden limb claudication, what you would have in that case, it would have gone to the lower extremity vasculature. But in this case, it goes to the superior mesenteric artery, and you get an embolism there, and it cuts off blood flow to your colon. So usually cardiac in origin, but it can be non-cardiac in origin. But we're gonna just think of cardiac in origin because that's like 85 to 90% of cases. So these patients usually have AFib or they're post-MI. So those are some risk factors for acute mesenteric ischemia. Another way you can get it is through thrombosis. And this is often called, again, like we see in the lower extremity diseases, acute on chronic disease. Why? Because with thrombosis, it's due to a rupture of a pre-existing plaque. Remember, back to second year medical school pathology, a plaque can be it can be a stable plaque, or it can rupture and become an unstable plaque. When it's an unstable plaque, it attracts all those platelets, and then you get a full-on occlusion. And so that can be another cause of an acute occlusion, because you have a plaque that suddenly ruptures, and then it pulls in platelets, and now you have a sudden blockage. So this is acute on chronic, and the reason we call this acute on chronic is because how do you have a plaque there in the first place? Well, usually you have to have the risk factors for atherosclerosis, and if you already have a plaque in your superior mesenteric artery, you probably already have chronic mesenteric ischemia to begin with. Probably, but not always. That's why it's called acute on chronic. A lot of these patients who develop acute mesenteric ischemia due to a thrombosis have chronic mesenteric ischemia because they've got all the atherosclerosis down there already. But you don't already have to have the diagnosis necessarily to have it be due to a thrombosis. It's just usually that's the case. So a lot of times these patients are going to have past history of chronic mesenteric ischemia or other peripheral vascular diseases, such as you could have diseases of the vasculature in your legs. You could have carotid artery disease. You could have coronary artery disease, atherosclerosis elsewhere, etc. So embolism and thrombosis are the most common causes of acute mesenteric ischemia. One more cause that you can see is what's called non-occlusive mesenteric ischemia. And what's really the only other way you can have reduced blood flow? Well, if you go into shock. If you've got severe hypotension, so cardiogenic shock, severe hypotension, high doses of vasoconstrictors or inotropics, anything that causes a low flow state to anywhere else in the body but the mesenteric vasculature. So embolism, thrombosis, and non-occlusive mesenteric ischemia. These are your three causes of acute mesenteric ischemia. But like I said, most commonly it's due to an embolism. All right, so remember that your superior mesenteric artery is most commonly implicated. And usually it's going to be distal, where it's going to cut off the ileocolic, right colic, and middle colic. So it's going to affect not so much your small intestine, but mostly your large intestine. All right, so what's the history in a patient with acute mesenteric ischemia? Well, they're going to have risk factors for the various causes. So remember that emboli is the most common cause, so what are the risk factors for emboli? Well, atrial fibrillation, being in a post-MI state, those both put you at risk for developing emboli in your heart. So atrial fibrillation, you get the embolism developing in your left atrium, and that's because you're not getting normal rhythmic contraction of your left atrium. So you can develop a clot there, and then that can go out into your aorta and then lodge into the mesenteric vasculature. Post-MI state, again, because you're not getting normal contraction of your left ventricle, so you can develop a clot there. Then patent foramen ovale, that's, if you have a patent foramen ovale, you can get a venous thrombus or a venous embolism, and then it crosses into the left heart circulation and then goes into the aorta. And then an abdominal aorta. If you have an abdominal aortic aneurysm, you can get a clot on the sides where you're not getting normal flow. So these are some risk factors for developing emboli. The absence of peripheral artery disease or chronic mesenteric ischemia is another thing that would make a patient more likely to have the acute mesenteric ischemia versus the chronic mesenteric ischemia. However, what's most identifiable for acute mesenteric ischemia is that you have the sudden onset of symptoms. So what are these symptoms? This is severe pain, severe abdominal pain that's out of proportion to physical exam. That's how it's classically defined. But I don't really know how you would see that on physical exam. I mean, a patient comes in with severe abdominal pain, you touch them, it elicits abdominal pain. I don't know what that means by out of proportion to physical exam. It's just severe abdominal pain, and it was a sudden onset. 75% of these patients also have nausea and vomiting, and that's usually just due to the severe pain. They may also have abdominal distension. They could also have diarrhea, and oftentimes that's going to be with blood. Why is it going to be with blood? Because you're starting to have some initial necrosis of your colon, and so that's going to put blood into the stool. And so if you can get a stool sample on these patients, if they do have a bowel movement, you're going to want to get right on that and check it for blood, because that's going to help you with this diagnosis. As the symptoms progress, the patient will develop septic symptoms, just because you're getting bowel necrosis, and that's going to spill bacteria into the bloodstream. And then you'll also have rectal bleeding. And what we're talking about here is not blood in the stool. We're talking about frank blood just pouring out of the bowel, because you're getting bleeding into your bowel. But these are later symptoms. Now, I want to point out, probably didn't refer to it earlier, but with this severe pain that you see in acute mesenteric ischemia, a lot of times this is not responsive to even some of your strongest painkillers. So you could give the patient morphine, and a lot of times they're still going to have their abdominal pain. So this is how bad it is. So you need to have a very, very, very high index of suspicion. Usually this is in older patients, but particularly if a patient has any history or presence of AFib, or if they're post-MI, etc., you need to have a high index of suspicion for this, because the earlier you diagnose this, the better the patient's chances at surviving are. They already have a dismal chance of surviving, only 20%. But the quicker you diagnose it, the better chance they have of being in that 20%. When you do suspect it, what do? You do angiography. So angiography of the abdominal aorta. And this can be done in various different ways. Primarily now we do CT angiography, but it can also be done the classic way, or even MRI angiography theoretically. But you want to make sure that you're getting this done as quickly as possible and rolling on to surgery as soon as you can. So what do we do for treatment once we've diagnosed them? Well, first, as always, we want to attend to the ABCs. That we're going to do before we diagnose them. We want to make sure that the patient has a stable blood pressure, because remember, they can go into sepsis. And if these patients have had severe diarrhea beforehand, they may be dehydrated, so you wanted to start fluids as quickly as possible. You're also going to want to make sure you monitor their saturation, because if they do have sepsis, that will start to decline. So you're going to want to make sure that these patients have saturation somewhere in the upper 90s. You want to start broad-spectrum antibiotics. Why? Because we're prophylactically concerned about sepsis. A lot of these patients will go on to develop sepsis if you don't give them broad-spectrum antibiotics. So we're going to want to make sure that we're covering everything, but particularly the gram-negatives and anaerobes. So things like second-generation cephalosporins, cefoxitin, cefotetin, those are good drugs to give. Carbapenems are even better. Those are like meropenem, imipenem. And then also some of the combined beta-lactamase inhibitors. So piperacillin, tazobactam, and then ticarcillin, clavulanate are some drugs you can give as well for the broad-spectrum coverage. And then finally, we're going to want to make sure we heparinize these patients if we suspect them of acute mesenteric ischemia, or especially if we diagnose them with acute mesenteric ischemia, because we want to make sure that any further problems that may come up, especially if it's a thrombotic cause, we want to make sure that we don't get more problems. So we want to heparinize these patients unless contraindicated. The surgical therapy is going to depend on the underlying cause. And again, this harkens back just like with your extremity disease. So if it's an embolism, the procedure of choice is going to be an embolectomy. With acute mesenteric ischemia, it's going to usually be an open embolectomy. And the reason that we do an open embolectomy as opposed to a catheter embolectomy is because we need to already we've got to already go into their bowel to make sure that, see if there's any necrosed bowel. And if there is, we need to take that out. So you're going to have to go in anyway, so you may as well just take the embolism out the old-fashioned way. There's really no point in doing catheters because you're going to have to open them up anyway. So an open embolectomy is what we do if if it's an embolism. If it's thrombosis, then the procedure of choice is going to just be an arterial bypass. We're going to need to do that anyway if there's thrombosis, because these patients often have chronic mesenteric ischemia with this acute issue on top of it. So we'll do an emergency arterial bypass, and the procedure of choice is an aortomesenteric bypass, where we're just skipping over the diseased part of the superior mesenteric artery and making a bypass. And usually this is going to be with a prosthetic graft. And then if it's the non-occlusive mesenteric ischemia, the treatment of choice is going to be vasodilators. What is usually done here, I've never seen this done, but I've read about it and talked to some surgery residents who apparently have seen it done, but I'd never heard of it until recently. This is to give vasodilators, but not only do we give them vasodilators, it's actually injected straight into the vessel that's affected. So usually the superior mesenteric artery. So it's done with radiologic guidance, but you actually just inject this vasodilator straight into the vessel that's affected. And the drug of choice that's given is papaverine. So also, in addition to the surgical treatment to treat the underlying cause, you're also going to need to remove necrosed bowel. And then a second look laparotomy is going to be indicated as well, just because they may have additional necrosed bowel, which isn't apparent on initial surgery. And so that should be done at approximately the 24-hour point. You don't need to worry about making the call as to removing necrosed bowel or doing a second look laparotomy. That's all going to be the surgeon's call. But what you do need to know, especially for the USMLE, is the medical treatment that we're giving these patients, broad spectrum antibiotics, that we're heparinizing them, of course also that we're doing the ABCs, and then the surgical treatment, that if it's an embolism, we're doing embolectomy, if it's thrombosis, we're doing bypass, non-occlusive mesenteric ischemia, then we're doing vasodilators. So this is an open embolectomy. I should have probably labeled it here, but you can see where they're going in here. They're actually cutting in right here, but this is the abdominal aorta, and you can kind of see here, this is the bifurcation to the common iliac arteries. So this is necrosed versus healthy bowel. It's going to be really obvious when you see it. So if there's already necrosed bowel, you're going to want to take this out, because if you leave this in, the patient's going to develop sepsis. So you want to take that out. So this is an aortomesenteric bypass. What you've got down here is your superior mesenteric artery, and then here's your abdominal aorta, and you've just made a conduit from your abdominal aorta to your superior mesenteric artery, bypassing the blocked part. And this is going to be what you're going to do if the patient has that acute on chronic mesenteric ischemia, where they've got the atherosclerosis already there. Okay, so what is chronic mesenteric ischemia? We've talked about it. That's the slowly progressive occlusion. So this is not something that comes on all of a sudden. These are patients who've had a history of these GI symptoms, and it's been going on for a while. So these are patients also have a history of atherosclerosis. Why? Because atherosclerosis causes chronic mesenteric ischemia. So they may have atherosclerosis elsewhere. They may have a history of MI. They may have a history of carotid artery disease. They may have a history of peripheral artery disease in the limbs. Those are all things that point towards a risk towards chronic mesenteric ischemia. Another thing you might see is weight loss, and that's because of the pain that they have when they eat. They're going to avoid eating. And that goes into what your symptoms are. So these symptoms, this is a slow onset of symptoms. This is not a sudden thunderstrike onset of pain that you see in acute mesenteric ischemia. This is a slow onset of symptoms. And there's this classic triad that I would expect the USMLE to give you if they give you a patient vignette, because this is something that surgeons want you to know. And that classic triad is postprandial abdominal pain, usually coming around the 30-minute to 2-hour point after eating. Then this food phobia, and of course that makes sense because if you get pain every time you eat, you're going to avoid eating. And then weight loss, and that's just due to not eating. So postprandial abdominal pain, food phobia, and weight loss. And they're all kind of linked together as to what's causing them. What do we do to diagnose chronic mesenteric ischemia? We do angiography or arteriography, same thing. So best diagnostic test is angiography. And the nice thing with chronic mesenteric ischemia patients is that we're not as rushed to get this. So you can do this either the classic way, the CT angiography, MR angiography, doesn't really matter. I would expect on the USMLE they'll just ask you angiography. You won't have to decide between those three because that's way beyond the scope for the USMLE. So best diagnostic test is angiography. You can also get a CT to rule out any other gut disorders, but the best diagnostic test is angiography. And the treatment, because this is a chronic disease, because you've got atherosclerotic plaques, you're going to need to actually just do a bypass. There's really you're not going to be able to take anything out. So we just do that same bypass that you saw that if you had acute on chronic disease with the acute mesenteric ischemia, we basically do the same thing. It's an aortomesenteric bypass. Usually with chronic mesenteric ischemia, we're not worried as much as we are with acute. We're not worried as much about necrosed bowel because it's developed over so much time that you've been able to develop your collateral circulation. So we're not as much worried about those life-threatening problems. So aortomesenteric bypass is the procedure of choice. And exactly what procedure you do, where you do the bypass, you don't have to worry about that, but that's all going to be based on your angiography and where the blockage actually is. Okay, finally, mesenteric venous thrombosis. So venous thrombosis in general, like deep venous thrombosis, is associated with hypercoagulable states, and that's no exception for mesenteric venous thrombosis. So it's really important in general for the USMLE and for clinical practice that you know the major risk factors for hypercoagulability. So there's the inherited diseases, so factor V Leiden, protein C deficiency, protein S deficiency, patients with lupus who have the lupus anticoagulant, and then the disease known as polycythemia rubra vera. All of these are risk factors for thrombosis, for hypercoagulability. And then there's also the acquired or environmental causes. So cancer, if you have cancer, that puts you at risk for hypercoagulability. If you take oral contraceptives, especially if you take oral contraceptives and you smoke, that's a big no-no. So that's another thing that puts you at risk for this. And then liver disease, because you're not making protein C and protein S, puts you at risk for thrombosis. So those are some of the causes of acquired hypercoagulability, but there's tons of them. So these are the big ones that you should be aware of. And then prior history of DVT or pulmonary embolism, that kind of is related to these other ones, but the reason that I put this in particular here is that the patient may not know that they have an inherited hypercoagulability. So if they have a past history of DVT or pulmonary embolism, if they haven't been worked up already, but they tell you they have had DVT or pulmonary embolism, that's a major red flag that they've got one of these inherited risk factors. So what are the symptoms for mesenteric venous thrombosis? So this is sort of in between, the clinical picture, it's sort of in between acute mesenteric ischemia and chronic mesenteric ischemia. This is sort of a subacute development of pain where it hasn't been going on for months and months and months, but it wasn't all of a sudden I can name you exactly what hour this came on. So this is a subacute progressive abdominal pain. Usually it's been around for about a week. And you can also get some abdominal distension and some problems with motility, which would be diarrhea or constipation, usually diarrhea. And patients with mesenteric venous thrombosis, in comparison to the patients with the acute mesenteric ischemia, which certainly should be on your differential, usually these patients are younger. They're not the older patients. that have like atrial fibrillation or post-MI, and usually the symptom onset is going to be much more insidious. The patient is not going to be able to tell you, oh, this just suddenly came on today. Usually they'll say, oh, it's been going on for a few days or a week, and it's going to be much less dramatic. These patients aren't going to be in nearly the same degree of pain that the acute mesenteric ischemic patients are in. And 27% of patients have had symptoms that have lasted longer than a month. So that just goes to show you that this is much more subacute, much more progressive than the acute mesenteric ischemia. For diagnosis, we're going to do a CT with contrast. We can't do angiography because where's the problem? It's in the veins. So we're going to do a CT with contrast. That's going to be your best initial diagnostic test. And the treatment here, 75% of patients won't need surgery. So initially what we're going to do is we're going to heparinize these patients and then treat whatever underlying disorder is there. So if there's an inherited disorder, we're going to want to work up for that. Usually we're not going to be able to treat that directly. But if there's an acquired cause, so if they're taking oral contraceptive pills, we're going to want to tell them to quit that. If there's liver disease, we can treat that depending on the cause. So you can usually work your way around these acquired diseases. So you're going to want to treat the underlying disorder. IV heparin and treat underlying disorder. In 25% of patients, they will need surgery. But for the most part, what you need to know for the USMLE is that you're going to use IV heparin and treat the underlying disorder. This does not warrant immediate surgical intervention.